Good evening and welcome to our webinar, which will focus on autoimmune liver diseases in the pediatric population. I'm Bill Balistreri, Cincinnati Children's Hospital. I will be the moderator for tonight's program. I will be joined by Dr. Carl Mack, Associate Professor of Pediatrics, Children's Hospital of Colorado, Dr. Alex Mifke, Assistant Professor of Pediatrics, Cincinnati Children's Hospital, and Dr. Tamir Milo, Director of Pediatric Hepatology and Liver Transplant Medicine, Texas Children's Hospital. For this program, Dr. Dipali Tiwari, Assistant Professor of Pediatrics, New York Medical College, served as the CME content reviewer on behalf of NASPGHAN. We want to first express our thanks to NASPGHAN and the NASPGHAN Foundation for sponsoring this webinar, and to Chris and John Browner, who provided support for this program. In addition, we'd like to acknowledge the following organizations that have endorsed this webinar: the Center for Autoimmune Liver Disease, Cincinnati Children's Hospital, PSC Partners Seeking a Cure, and Save John Research Accelerator. Before we begin, please note that following the presentations, we will take as many of your questions as time will allow. Please feel free to submit your question at any time during the webinar. The question box is located directly beneath the webinar player window. As you scroll down, you will also see the registration page, which contains directions on how to obtain CME credit. So let's begin. As mentioned, tonight we will focus on autoimmune liver diseases in the pediatric population, specifically the seemingly related disorders of primary sclerosing cholangitis, autoimmune hepatitis, and autoimmune sclerosing cholangitis. We have chosen to highlight these disorders for several reasons. Autoimmune liver diseases present a challenge for all of us. Their relative rarity creates gaps in understanding the approach to diagnosis and management, and this may result in the development of severe complications of these disorders, including progression to end-stage liver disease, the need for liver transplantation, and perhaps the development of cholangiocarcinoma. So on the next slide, our objectives are outlined, and these are to describe the spectrum of autoimmune liver disease that may occur in children and adolescents, to review their pathophysiology, natural history, and clinical presentations, to suggest a diagnostic approach, to explain the potential therapeutic strategies, and to review the indications and outcome following liver transplantation. Let me underscore on the next slide the clinical dilemma by presenting the case of a 13-year-old boy known to have ulcerative colitis. He now presents to you with fatigue and new onset jaundice. On exam, you note hepatosplenomegaly. Screening studies reveal elevated levels of conjugated bilirubin, AST, ALT, and alkaline phosphatase. An abdominal ultrasound confirms your examination. So you are now faced with a task of planning and evaluation. As shown on the next slide, the most likely consideration, given this clinical scenario, is that this may represent either autoimmune hepatitis or sclerosing cholangitis. Next, in fact, there is a valid third consideration, an entity with histologic features which overlap these two. Next slide. This overlap syndrome, which is most commonly seen in children and young adults, presents with clinical, biochemical, and histologic features of autoimmune hepatitis in the presence of cholangiographic features of sclerosing cholangitis. Next. This overlap syndrome has been termed autoimmune sclerosing cholangitis, or ASC. On the next slide, you'll see that the incidence and outcome of these seemingly related disorders was recently studied in a cohort of children in Utah. In a review of 600 children with IBD, the investigators identified autoimmune liver disease in 85 patients. Specifically, they reported 29 cases of sclerosing cholangitis, which occurred in 10% of patients with ulcerative colitis and in less than 1% of children with Crohn's disease. They also detected 44 cases of autoimmune hepatitis with a concomitant presence of IBD in only a small percent of the cases. There were 12 cases of autoimmune sclerosing cholangitis, and this occurred in 2.3% of patients with ulcerative colitis and in approximately 1% of children with Crohn's disease. On the next slide is a Venn diagram from that report, which depicts the variable degree in which patients with PSC, ASC, and autoimmune hepatitis emerge from the IBD cohort. And on the next slide, you can see that the investigators also reported the outcome of the children in this cohort. This graph emphasizes that a greater proportion of patients with PSC progressed to complicated liver disease than patients with autoimmune hepatitis. Of note, the rate of progression of patients with ASC more closely paralleled that of PSC. Of note, on the next slide, they describe the development of cholangiocarcinoma in 2 of the 29 children with PSC. Next slide. So in summary, our case and the data from Utah clearly highlight the challenges encountered. We must recognize new onset disease, especially in our patients with IBD. We must be able to rapidly and precisely differentiate in view of the prognostic implications. We must establish and monitor an effective treatment plan. And clearly, we must conduct and support research in the area of autoimmune liver disease in the pediatric population. So I would now like to introduce Dr. Tamir Marlow, who will contrast these disorders and discuss their evaluation. Tamir.
Okay, thank you very much, Bill. So let me take you through the case of the 13-year-old patient who presented with abdominal pain, fatigue. So as you can see, when we look at the classical symptoms of PSC, most of the patients are asymptomatic at the time of presentation, and there's a significant male predominance in patients with primary sclerosing cholangitis. Some of the symptoms may be related to the pre-existing inflammatory bowel disease. However, specifically looking at PSC symptoms, many of the patients would report fatigue, vague abdominal pain, anorexia, weight loss, poor growth, pruritus, fevers, mostly in the setting of cholangitis, jaundice, and fat soluble vitamin deficiencies as a result of the obstruction. And since a lot of these patients have fatigue, they may report impaired quality of life and depression. In contrast, in autoimmune hepatitis, there is a definite female predominance. Again, most of the patients would be asymptomatic at the time of presentation, and some of the symptoms may be related to extrahepatic immune-mediated diseases that occasionally are associated with autoimmune hepatitis, such as thyroid problems, celiac, and the autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy. Some of the patients can have low-grade fevers, right upper quadrant pain, arthralgia, jaundice, and in both diseases, you can have symptoms associated with end-stage liver disease, cirrhosis, and portal hypertension. Next slide. Autoimmune hepatitis can present with a spectrum of symptoms. Starting with acute hepatitis would be very similar to any viral hepatitis. Patients can present with a fulminant acute liver failure, and other patients can have a chronic liver disease and present with symptoms associated to cirrhosis and portal hypertension. There are specific unique features to autoimmune hepatitis, as some may present with drug-induced autoimmune hepatitis, with the most common drug in pediatrics being minocycline for acne, but other drugs such as interferon and other antibiotics can present the same way. Some of the autoimmune hepatitis can present with overlap with PBC and primary sclerosing cholangitis, and there may be recurrence of the autoimmune hepatitis after liver transplantation in patients who were transplanted for the autoimmune hepatitis indication. And some patients can have de novo autoimmune hepatitis, which are features similar to autoimmune hepatitis in patients who are transplanted for other causes than autoimmune hepatitis. Next slide. So in physical exam, initially it is unremarkable, and it really depends at what time in the spectrum the patients are being examined. Patients can present with jaundice, hepatomegaly, splenomegaly, excoriations due to the pruritus, a small percentage with ascites, and other symptoms associated with or physical findings associated with cirrhosis and portal hypertension. Next slide. The typical laboratory blood tests in primary sclerosing cholangitis would be more of the biliary injury type with elevated alkaline phosphatase and GGT. Bilirubin is elevated in up to 40% of the patients, and they may have evidence of end-stage liver disease such as pancytopenia and low albumin and occasionally coagulopathy. P-ANCA would be positive anywhere between a third to 87% of the cases. IgG4 may be elevated in 10% of the patients, and up to 70% will have positive autoimmune markers, however, with negative histology, which means that positive autoimmune markers are not necessarily diagnostic of autoimmune hepatitis, but may be in primary sclerosing cholangitis. In autoimmune hepatitis, on the other hand, you have predominance of hepatocellular injury, with ALT and AST being higher than alkaline phosphatase and GGT. Bilirubin initially is normal, however, may increase with end-stage liver disease. Quantitative immunoglobulins are elevated. In autoimmune hepatitis type 1, ANA, antinuclear antibody, anti-smooth muscle antibody, and anti-F-actin are elevated. And in autoimmune hepatitis type 2, you have positive anti-liver kidney microsome and anti-liver cytosol positive antibodies. Next slide. The differential diagnosis is very wide, really depending on how the patient presents, anywhere between acute presentation to chronic presentation. Important things to rule out would be viral hepatitis, Wilson's disease, drug-induced liver injury, alcohol consumption in older patients, granulomatous hepatitis, which may be seen in patients with inflammatory bowel disease, hemochromatosis, mostly in older patients, celiac, non-alcoholic steatohepatitis, and alpha-1 antitrypsin. Though we discuss primary sclerosing cholangitis, it is very important to rule out secondary causes of sclerosing cholangitis, which would be immunodeficiencies in smaller children, genetic diseases, cystic fibrosis, and progressive familial intrahepatic cholestasis type 3 may present very similarly to PSC. Surgery, trauma, stone, tumors, and pancreatitis all present obstruction to the biliary tree and may present similar to PSC. Vascular injury and ischemia, and infections. All of these could cause secondary sclerosing cholangitis. Next slide. When you image patients with PSC and overlap autoimmune hepatitis, the ultrasound is usually normal. On MRCP, you would find multifocal strictures and dilatation involving the intra and or extrahepatic biliary tract. Typical findings you could find on MRCP would be beading and pruned tree. An ERCP was considered the golden standard and is mostly used if MRCP is equivocal. The advantages of an ERCP would be that it could be used for intervention such as stent placement and balloon dilatation, and could be used to screen for cholangiocarcinoma. However, the disadvantages of an ERCP are that it is invasive, involves sedation, and there is a high risk of pancreatitis. It is also better to visualize extrahepatic lesions rather than intrahepatic lesions. MRCP is very sensitive in children and is usually the first screening tool. Its advantage is that it is non-invasive, does not involve radiation, there is no pancreatitis risk, and is good to image injuries proximal to the strictures and also extraluminal abdomen. Histology, the typical findings you would find in primary sclerosing cholangitis would be ductal proliferation, periductal inflammation, and ductopenia. This slide shows classic onion skinning, however that is very rare and is found in progressive forms of PSC. Other features would include cholestasis and different degrees of fibrosis. In order to diagnose PSC, usually you do not need a liver biopsy. Liver biopsy is used when you are considering the diagnosis of small duct PSC, in which you have biochemical markers of PSC with a normal imaging. If you wanted to rule in overlap with autoimmune hepatitis, you would need a liver biopsy. If the differential diagnosis includes other diagnosis and to stage the disease. Next slide. In autoimmune hepatitis, you would find interface hepatitis, plasma cell infiltrates, rosette formations, bridging necrosis, different degrees of fibrosis leading to cirrhosis, and the bile ducts are usually spared in autoimmune hepatitis. In overlap autoimmune hepatitis, you would find a little bit of both. You'd find interface hepatitis, plasma cell infiltrates, which is typical of autoimmune hepatitis, plus ductal proliferation, periductal inflammation, ductopenia, cholestasis, and fibrosis. Next slide. This table shows the simplified criteria to diagnose autoimmune hepatitis. The maximum points one could get is 8, with more than 6 points probable autoimmune hepatitis and 7 or more points definite autoimmune hepatitis. And these criteria include autoimmune antibodies, ANA, anti-smooth muscle, liver kidney microsome, and soluble liver antibodies, the quantitative immunoglobulins. They must include histology and ruling out viral hepatitis. Next slide. Now I would like to discuss screening of high-risk populations, in particular patients with inflammatory bowel disease. So inflammatory bowel disease is present in 53 to 96% of all pediatric PSC cases. And on the flip side, 5% of patients with inflammatory bowel disease will develop PSC during their life. Ulcerative colitis is much more common than Crohn's disease and can present with pancolitis, some case reports with rectal sparing, backwash ileitis, and in many patients it is quiescent at the time of presentation. The next cartoon shows the different presentations of inflammatory bowel disease when up to a third of the patients can present with rectal sparing, many have pancolitis, mild inflammation, mostly asymptomatic. There is a right side predominance of inflammation and backwash ileitis. Crohn's colitis presents in approximately 10% of patients with PSC. The IBD is usually diagnosed first or concurrently with a PSC, but may present later and even after a liver transplantation for PSC. And the course of the PSC does not correlate with the course of inflammatory bowel disease, meaning you can have a flare of inflammatory bowel disease and a quiescent liver disease, and vice versa, you could have an advanced liver disease with a very quiescent inflammatory bowel disease. It is recommended that once you diagnose a patient with PSC, even if the patients are asymptomatic from an IBD standpoint, you would perform a surveillance colonoscopy and could definitely find quiescent inflammatory bowel disease. If these patients need surgery, the risk of pouchitis is anywhere between 13.8% to 90%. And in adult patients with PSC, the 10-year cumulative risk for cholangiocarcinoma has been reported to be up to 10%, and therefore it is recommended in adult patients to screen patients who have inflammatory bowel disease and PSC with annual colonoscopies. The differential diagnosis of increased aminotransferases in inflammatory bowel disease is again very wide. In a report from Valentino published in 2015, it was found that close to 60% of patients with inflammatory bowel disease had abnormal liver enzymes within 150 months of diagnosis, and 16% had abnormal liver enzymes 1 month after the diagnosis of inflammatory bowel disease. In this series, 4.3% had PSC and 1.7% had autoimmune hepatitis. However, there are other chronic liver diseases that you could see in patients with inflammatory bowel disease, such as non-alcoholic fatty liver disease, PBC, hepatic amyloidosis, granulomatous hepatitis, portal vein thrombosis due to the hypercoagulability, infections, especially when using immunomodulators, liver abscesses, and drug toxicities for the medications to treat IBD. In the next slide, you can see a series by Goyal that was published in 2014 when they looked at close to 1,600 children with inflammatory bowel disease, and they found liver disease in 2% of these patients. 21% of them had PSC, 2 autoimmune hepatitis, and 6 overlap. The liver disease was far more common in patients who had ulcerative colitis, 4%, in comparison to 0.8% of patients who had Crohn's disease. And it was found that if you'd had elevation of ALT and GGT 3 months after the diagnosis of IBD, you had a markedly increased likelihood of having a chronic liver condition. In my last slide, I wanted to share with you also the screening for cholangiocarcinoma. So the lifelong risk of cholangiocarcinoma is 10%. Interestingly, 50% of these cases are diagnosed within the first year of diagnosis. It is very rare in pediatrics, and there are only a few case reports of cholangiocarcinoma diagnosed in children with PSC. The cholangiocarcinoma may be intrahepatic, hilar, or extrahepatic. Many of the patients are asymptomatic at the time of presentation, but as the cholangiocarcinoma progresses, they may have abdominal pain. Laboratory-wise, there is a marked elevation of alkaline phosphatase and CA19-9, and in imaging, you would find a dominant biliary stricture. The diagnosis may be done through brushing cytology, FISH, or biopsy. And now, I would like to introduce Dr. Mitke, who will talk about the pathogenesis of autoimmune liver disease.
Thank you, Tamir, for the introduction. I will start my overview on selected aspects of the pathogenesis of autoimmune liver disease in children by highlighting a few differences between autoimmune hepatitis and PSC. Importantly, whereas the immune injury is directed against hepatocytes in autoimmune hepatitis, the bile duct epithelial cells represent the primary cellular target of injury in PSC. Autoimmune hepatitis on the one side commonly occurs in conjunction with other autoimmune disorders as reviewed by Tamir, like celiac disease or autoimmune thyroiditis, but is accompanied by IBD in less than 10% of the patients. In contrast, as we heard before, IBD is associated with PSC in more than 60% of the patients. Whereas insidious progression of hepatic fibrosis is a primary complication of autoimmune hepatitis, sequelae of chronic cholestasis, development of ductal strictures, and cholangiocarcinoma are the main concerns in PSC. Biliary fibrosis, though, is a long-term consequence of biliary injury in PSC. Next slide, please. Not only the types of autoimmune liver disease, PSC and autoimmune hepatitis, differ from each other. The age of onset also seems to impact the clinical phenotypes. This slide displays a Venn depicting the overlap of PSC with other conditions in adults as well as in children with PSC. Between 9 and 15% of adult patients with PSC have elevated serum IgG levels, which is used to screen for IgG4 autoimmune sclerosing cholangitis. This condition has recently been recognized as a subgroup of PSC, which has distinct clinical manifestations and prognosis. In contrast, this overlap is very uncommon in pediatrics, at least based on case series published to date. On the other side, overlap with autoimmune hepatitis occurs in up to 30% in patients with pediatric onset PSC and is only reported in 5 to 10% of adults. These are a few of several differences between adult and pediatric onset autoimmune liver disease, and they are important to bear in mind when we talk about concepts of pathogenesis of autoimmune liver disease, which are primarily based on studies in adults. Next slide, please. Like the presenters before, I would like to spend a few words on the overlap condition autoimmune sclerosing cholangitis. The observation of frequent coexistence of autoimmune hepatitis and PSC in children has raised the hypothesis that autoimmune hepatitis and PSC may indeed present extremes of a disease continuum of autoimmune hepatobiliary injury. In case reports, a transition from autoimmune hepatitis to PSC with gradual increase in biliary injury has been reported. Under this paradigm, autoimmune liver disease can be viewed from the perspective of progressive evidence of biliary lesions in a reciprocate relation with biochemical response to corticosteroids. The more biliary injury occurs, the more cholestatic is the phenotype, and the less likely becomes clinical response to steroid. Although this concept is appealing and has likely guided many of us in our clinical approach to pediatric onset autoimmune liver disease, its pathophysiologic validity remains to be tested. It will later on discuss what clues can be derived from genetic studies regarding the concept of a disease continuum of autoimmune liver disease. Next slide, please. On a histomorphological level, both diseases, autoimmune hepatitis and PSC, coexist in patients with autoimmune sclerosing cholangitis. This slide illustrates the liver histology you may find in a patient with sclerosing cholangitis as described by Dr. Balestrieri in his introduction. The photomicrographs in the upper panel are from H&E stained liver sections. The blue arrow on the left denotes interface hepatitis and piecemeal necrosis of hepatocytes. The red arrow on the right denotes immune cells infiltrating an interlobular bile and dystrophic changes of the epithelium, which are the hallmarks of PSC. The lower panel shows abundance of the two main lymphocyte populations implicated in the pathogenesis of autoimmune liver disease. T lymphocytes stained with anti-CD3 in the left lower panel and CD20 positive B lymphocytes in the right lower panel. Both subpopulations are highly prevalent in the vicinity of the portal tract as well as in an adjacent lymph follicle. Most importantly, both cell types not only infiltrate zone 1 hepatocytes but also the bile duct epithelium, clearly distinguishing autoimmune sclerosing cholangitis from the condition autoimmune hepatitis. Next slide, please. Our current understanding of the pathogenesis of autoimmune hepatitis and PSC builds on more than 40 years of research. One of the first studies was a report in Lancet in 1973 on the outcomes of treatment of active chronic hepatitis with prednisone and azathioprine. Subsequently, it was hypothesis-based research which attempted to delineate the basis for autoimmune liver disease. For instance, by identifying antigens recognized by the various autoantibodies detected in patients with autoimmune hepatitis. More recently, the most insightful results originate from hypothesis-3 genome-wide association studies in both conditions, and the validation of these genetic associations using human tissue and animal models. Despite decades of work on animal models for PSC and some excellent models like the MDR2 knockout mouse, which is used to study chronic cholestasis and biliary fibrosis, none of these models recapitulates all or at least the majority of changes in PSC, especially the large duct disease or the association with colitis. Next slide. Going forward, I selected a few immunologic principles which I believe are critical for the understanding of the pathogenesis of autoimmune liver disease. Every step in the pathogenesis likely involves a genetic predisposition and requires environmental triggers exposing to disease manifestation. First, I will focus on autoimmune hepatitis. The development of autoimmune hepatitis requires presentation of an autoantigen on the surface of hepatocytes. For type 1 autoimmune hepatitis, it is still uncertain which autoantigens are merely recognized by the autoantibodies ANA and SMA, and which are actually pathogenic and trigger the immune response. Cytochrome P450-1A2 and sialoglycoproteins belong to the putative antigens. In contrast, the pathogenic autoantigen for the much less common type 2 autoimmune hepatitis is well delineated. CYP2D6 is recognized by the LKM antibodies, as well as it is found to be pathognomonic for the disease onset. Importantly, in a recent study published in Hepatology 2015 by Axel et al., it was found that if plasmids are injected into mice with a haplotype HLA-DR3, these mice develop autoimmune liver disease, very reminiscent of autoimmune hepatitis. Importantly, viral infections like EBV disease and exposure to certain drugs have been described to lead to upregulation of major histocompatibility complexes on hepatocytes presenting these autoantigens. Next slide. However, expression of the autoantigen alone does not lead to immune injury. In order to elicit T-cell mediated immune injury, the autoantigen needs to be presented by antigen-presenting cells like dendritic cells. Interestingly, and perhaps disappointingly for the investigators, the only genome-wide association study so far in autoimmune hepatitis, which enrolled 649 patients with type 1 autoimmune hepatitis in the Netherlands and 450 patients for validation in Germany, discovered only one area on the genome to be highly associated with the disease. Not surprisingly, it showed a very strong correlation of type 1 autoimmune hepatitis with the major histocompatibility complex MHC2, specifically with the alleles HLA-DR3 and HLA-DR4. Of note, HLA-DR3 and HLA-DR4 are also highly associated with pediatric onset autoimmune hepatitis type 1, whereas HLA-DR7 is linked to type 2 autoimmune hepatitis. The surprise of this study may stem from the lack of any other genetic associations and pathways furthering our understanding of the disease, as will you appreciate when we will review the data on PSC. In summary, only if presentation of autoantigens on hepatocytes following a viral illness or certain drug exposure occurs in an individual with a permissive MHC2 haplotype, the cascade of immune activation and injury gets initiated. Next slide. These dendritic cells are then able to present the antigen to helper CD4 cells, which then activate CD8 lymphocytes via secretion of interleukin-2 and TNF-alpha. These cytotoxic T cells directly lyse hepatocytes and recruit additional effector immune cells. This cartoon may help to understand that TNF-alpha antibodies like infliximab, a second-line therapy for autoimmune hepatitis, may disrupt the activation of cytotoxic CD8 lymphocytes, and why there is a rationale to use calcineurin inhibitors like tacrolimus in the treatment of refractory autoimmune hepatitis. One of the key questions of current research is how these T lymphocytes escape the mechanisms preventing autoimmunity, especially the negative selection in the thymus, as well as the peripheral control of autoimmunity by regulatory T cells expressing FOXP3. Especially studies in children have helped to identify the critical pathways of central and peripheral control of immune tolerance preventing the disease. For instance, children with mutations in the autoimmune regulator gene AIR have impaired thymic function and subsequently develop autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy, and autoimmune hepatitis in 20%. Mutations in the gene GATA2 as well as in the gene CTLA4 were detected in children with autoimmune hepatitis and defective function of regulatory T cells, and we present few examples of Mendelian disorders linked to autoimmune liver disease. Furthermore, studies in larger cohorts of patients with sporadic autoimmune hepatitis from King's College London showed effective response of Tregs in patients compared with healthy controls. Perhaps cell-based therapy which targets the fractured immune tolerance in autoimmune hepatitis through elimination of autoimmune T-cell clones or enhanced peripheral control by regulatory T-cells become the therapy of pediatric onset autoimmune hepatitis in the future. Next slide. Whereas the pathogenic role of CD4 and CD8 cells is supported by studies in patients and animal models, the role of B lymphocytes and plasma cells is less clear. Some studies, especially in animal models, suggest that B lymphocytes suppress CD4 T cell responses, while others suggest activation of cytotoxic lymphocyte responses through enhanced antigen presentation. Pathogenic plasma cells may secrete antibodies which bind to normal surface proteins on hepatocytes, which then leads to activation of NK cells and cytotoxic injury. Perhaps well-conducted studies on rituximab for refractory autoimmune hepatitis may help us to better understand the role of B cells in autoimmune hepatitis in the future. Next slide. As I pointed out before, the genome-wide association studies between autoimmune hepatitis and PSC are quite different. On this Manhattan plot, you see that there are several associations between the disease and various hotspots on the genome, not only the chromosome 6 encoding the alleles for the MHC2 haplotype. This largest study is on 3,789 Europeans with PSC, as well as 25,000 subjects in the control group, has dramatically changed our understanding of the pathogenesis of PSC. The next slide will show us some lessons we learned from these genetic studies. Similar to autoimmune hepatitis, the strongest risk factor for PSC is the HLA type. So these pathways of immune activation and onset of autoimmunity are not only relevant for autoimmune hepatitis but also relevant for PSC. Non-HLA genes implicate several pathways, some overlap with IBD. In summary, from several of these GWAS studies in PSC and meta-analysis, it can be estimated that disease onset and disease progression is determined to 30% by inherited and to 70% by environmental factors in PSC. It should be noted that the risk is tenfold increased in siblings of patients with PSC to develop this condition. The risk for siblings in autoimmune hepatitis, though, is actually not known. The next slide will go a little bit into details of some of the other SNPs which were detected in this last large GWAS study. And SNPs were found near the genes encoding for cytokine immune activation, the genes for IL-2, IL-21, and IL-2 receptor, genes encoding factors for T-cell homeostasis, CD28 and HDAC7. Interestingly, a polymorphism for FUT2, which is important for maintenance of the cholangiocyte bicarbonate umbrella, protecting from bile acid-induced injury, is associated with disease, and a risk allele was found in the second bile acid receptor TGR5. The precise role of these pathways is still being investigated. The next slide summarizes some of the important mechanisms linked to onset and progression of primary sclerosing cholangitis. The first pathway is the immune pathogenesis, and includes many of the principles I covered early on for the autoimmune hepatitis. The second pathway is the interesting dual homing theory which was developed in Birmingham, and it suggests that T lymphocytes get activated in the intestines migrate to the liver, exert injury to biliary epithelial cells, and then migrate back to the intestine where they rest as effector memory cells. The protein mucosal adjacent cell adhesion molecule MADCAM1 was found to be critical to mediate this process of homing of intestinal lymphocyte to the liver. The third theory is the leaky gut theory, and that was developed several years ago through studies in a rat model. And the fourth one is a toxic bile concept, in which toxic bile, for instance, in patients with mutations in the gene ABCB4, lead to bile duct injury. Both these theories have gotten more support recently through several studies on the microbiome in patients with PSC. Next slide, please. Here I just highlighted two of the very recent studies on the microbiome. It should be mentioned before we go into the details that actually a lot of the microbiome studies were negative in patients with PSC, but the positive ones include the first one, which is in an animal model, and the second one, which is in a patient cohort. In an animal model, as mentioned before, the MDR2 knockout mouse, it was found that the disease phenotype is worsened if these mice are raised in germ-free conditions. And the worsened liver injury was linked to reduced bile acid, protective bile acid levels surrounding the cholangiocytes. The human studies was conducted in 85 patients with PSC and healthy control, as well as controls with UC. And there were two important findings. One was that in patients with PSC, the diversity of the intestinal microbiome was actually reduced. And then they found one strain of Vancomycin genus which was associated with PSC. My last slide will summarize what we have discussed here. I presented to you the host genetics which particularly predisposed to PSC, especially the HLA type, IL-2, CD28, and the bile acid receptor TGR5. The less well understood genetic predisposition in autoimmune hepatitis, which primarily links to HLA. The important aspect of IBD and how it is associated primarily with PSC. Recent studies which may link the onset of PSC to Rationale microbiome as well as to reduced diversity. Which I have not covered is that tobacco actually decreases the risk of PSC. In our last section, Dr. Karamak will review for you treatment options for autoimmune hepatitis, autoimmune sclerosing cholangitis, and PSC in children.
Okay, thank you, Alex. And I would like to invite all the participants to please enter your questions and comments. The question area is located directly beneath the webinar player window. So you can do that at any time throughout the webinar session. Next slide, please. I'm going to start with therapeutic options for autoimmune hepatitis. Next slide. The standard therapy to treat autoimmune hepatitis entails the use of corticosteroids to induce remission and azathioprine to maintain remission. Corticosteroid use induces remission in over 90% of the cases. However, it may take up to 6 months for the liver transaminases to normalize, denoting a biochemical remission. Now, our group and others consistently measure the TPMT activity prior to initiating azathioprine to ensure adequate metabolism of the drug. Azathioprine is added for maintenance therapy, and the steroids are weaned off usually within 6 months. Once the liver tests have normalized, patients should be maintained on azathioprine therapy for a minimum of 2 years prior to the consideration of withdrawal of immune suppression. Next slide. Even though biochemical remission is usually achieved within 6 months, histologic remission, defined as normal liver histology on a follow-up liver biopsy, usually takes much longer. For type 1 autoimmune hepatitis, 65% of patients will achieve histologic remission by 18 months of therapy and 80% by 3 years of therapy. Type 2 patients rarely can be taken off medication as they frequently relapse. Now, even after you've got proven histologic remission in type 1 autoimmune hepatitis based on repeat liver biopsy, if a patient goes off all therapy, approximately 70 to 80% will relapse within the first year, requiring reinitiation of immune suppression. Next slide. Indications to consider liver transplant in the setting of autoimmune hepatitis include end-stage liver disease in patients who fail all therapies, acute on chronic liver failure, and fulminant hepatic failure. Autoimmune hepatitis accounts for 2 to 3% of all pediatric liver transplants, and autoimmune hepatitis accounts for up to 20% of all cases of pediatric fulminant hepatic failure. Next slide. Autoimmune hepatitis can recur after liver transplant. The diagnosis is suspected in the setting of chronic elevation of liver transaminases, and it's essential to rule out other causes of elevated liver tests, such as allograft rejection, biliary strictures, or viral infections. Children with recurrent autoimmune hepatitis post-transplant usually present with vague symptoms of lethargy or low-grade fever and the elevated liver tests. Autoantibodies are usually positive, one of the 3 standard autoantibodies, as well as elevations in total IgG levels, and the characteristic interface hepatitis should be present on liver biopsy. Next slide. Shown here is a summary of published studies on recurrent autoimmune hepatitis in adults. There's actually very few studies on recurrence in children. So in the summary of all these studies in adults, the average recurrence rate of autoimmune hepatitis was approximately 30%, and the time to recurrence ranged from 1 month to 5 years after transplant. In addition, approximately 12% of these patients required retransplantation due to their recurrent autoimmune hepatitis. Next slide. So in the past few years, new therapies for autoimmune hepatitis have emerged. The first entails the use of budesonide to induce remission. A randomized trial of prednisone versus budesonide plus azathioprine for all in 207 adults with autoimmune hepatitis revealed that budesonide was as effective as prednisone in inducing remission. Importantly, there were minimal side effects from budesonide compared to many steroid-specific side effects from the prednisone. They also learned in this study that budesonide alone is not effective at maintaining the remission. Now, a recent study on the use of budesonide to induce remission in children with autoimmune hepatitis also found that budesonide and prednisone were equally effective, and similar to the adult study, significantly less steroid side effects in the budesonide group. So I actually consider using budesonide for induction therapy in our patients who have a mild autoimmune hepatitis on liver biopsy and who have another concurrent disease that may be worsened due to the steroid side effects. And this includes in the setting of obesity, severe acne, or significant mental health issues. Next slide. Another medication that's been used recently for maintenance of remission is mycophenolate mofetil, or Cellcept. Cellcept can be considered in patients that do not maintain remission with azathioprine or who are intolerant to azathioprine. An adult study showed that patients who couldn't tolerate azathioprine and were switched to Cellcept, 71% achieved a sustained remission within 3 months. A pediatric study on the use of Cellcept in non-responders or patients intolerant to azathioprine also showed that 70% achieved remission with CellCept. Next slide. Now, the use of tacrolimus can be considered if the patient fails to achieve remission with azathioprine or CellCept. There's only been a few case series on the use of tacrolimus for maintenance therapy, and they've shown some promising results in the control of liver inflammation. However, larger studies would really need to be performed to determine the true rate of efficacy of tacrolimus for autoimmune hepatitis sustained remission. Primary use of tacrolimus for maintenance of remission is not recommended due to the increased rate of side effects, most importantly, the renal insufficiency in the setting of chronic tacrolimus use. Next slide. Now, a brief word on the treatment of autoimmune sclerosing cholangitis. When the autoimmune hepatitis component is treated with the standard prednisone and azathioprine, the vast majority of patients will achieve a biochemical remission. In the series shown here by Gregorio et al. From King's College, approximately 80 to 90% of patients attained normal values of AST, bilirubin, GGT, and alkaline phosphatase when treated for the autoimmune hepatitis component of their sclerosing cholangitis. 39% of these patients were weaned off of azathioprine after 2 years of therapy, and 17% remained off all immune suppression long term. This study also showed that treating the autoimmune hepatitis component does not alter the PSC disease progression. In that study, 17 patients with autoimmune sclerosing cholangitis had follow-up ERCPs. 9 of them had static disease, and another 8 had progressive stricturing. None of the patients had regression of their disease while on immune suppression. Next slide. Now we're going to finish by talking about potential treatments for primary sclerosing cholangitis. Next slide. Shown here is a short list of immunomodulatory and antibiotic therapies that have been attempted in adults with primary sclerosing cholangitis. None of these therapies in these previous historical trials have been shown to prevent progression of the disease. Next slide. As you all know, ursodeoxycholic acid is commonly used in children with primary sclerosing cholangitis at doses ranging from 10 to 20 milligrams per kilo per day. Ursodeoxycholic acid has many potential mechanisms of action, including the displacement of hydrophobic bile acids, inhibiting hepatocyte apoptosis or cell death, stimulating bile acid secretion, and even anti-inflammatory immunomodulatory effects. Next slide. So one small study on the use of ursodeoxycholic acid in children with PSC revealed that the GGT significantly decreased to normal or near normal levels and was associated with a trend in significant decreases in jaundice and pruritus. This study, however, was limited as they did not assess for improvement in fibrosis or progression of disease. For example, there was no follow-up liver biopsies or MRCPs. Next slide. Shown here is another study assessing the effect of ursodeoxycholic acid on liver function tests. Significant improvement was seen in all of the liver parameters after 1 year of ursodeoxycholic acid, and that group is shown in orange. However, again, no investigations were performed regarding the assessment of disease progression, for example, improvement in liver fibrosis or MRCP findings. So we still don't know if ursodeoxycholic acid really has an impact in the progression of pediatric PSC. What we do know is that there was a study published a few years ago in adults where they gave, I'm on the next slide, where they gave the adults high-dose ursodeoxycholic acid at 28 to 30 milligrams per kilo per day, versus placebo to 150 adults, and they found that the ursodeoxycholic acid group had significant improvement in their liver tests, similar to what we see in children at the lower dose therapy. However, this study also looked at progression of disease based on incidence of liver transplant or death, and they showed that there was a twofold increase in transplant or death in the high-dose ursodeoxycholic acid group. Because of this study, many adult hepatologists now are no longer prescribing ursodeoxycholic acid for their patients. Next slide. So many of you have also heard about the studies on the use of oral vancomycin for children with PSC. The use of oral vancomycin is based on the theory that vancomycin may alter your gut microbiome, resulting in decreased activation of innate immune responses in the liver. Oral vancomycin is not systemically absorbed, and therefore side effects are minimal or absent. Now, Ken Cox's group from Stanford has published the majority of work on vancomycin for pediatric PSC. In 2008, they assessed 14 patients given vancomycin who had PSC and active colitis, and the active colitis was either symptomatic colitis or histologic evidence of active colitis. All of these patients achieved normal liver tests while on vancomycin, and when the vancomycin was stopped, increase in liver tests were observed. One limitation to this study is that they did not look at the long-term parameters in response to vancomycin use. For example, no follow-up liver biopsies or MRCPs. This same group a few years later looked at 9 subjects with PSC and ulcerative colitis and found that those treated with vancomycin had significant increases in anti-inflammatory cytokines and regulatory T cells and decrease in the pro-inflammatory cytokines. They also did do somewhat subjective analysis of progression of disease with follow-up liver biopsies and MRCPs. And with the follow-up liver biopsies, their statement was that the liver biopsies had either normalized or there was minimal inflammation or fibrosis. Unfortunately, there was not a formal scoring system of liver inflammation and fibrosis pre and post vancomycin use, and so therefore the interpretation of the results is somewhat limited. Next slide. So these vancomycin studies seem somewhat promising, showing significant improvement in liver tests and subjectively in liver fibrosis. So why shouldn't every child go ahead and start vancomycin? There's a few words of caution. First of all the studies are pilot studies with small groups of patients. The patients that they looked at were a very unique population of patients who had PSC and active colitis at the time of treatment. And we need to really consider potential side effects of the use of long-term oral vancomycin, specifically the potential for creating highly resistant colonic bacteria that in the setting of the patient who then may need a liver transplant, they may have a highly pathogenic bacteria that is highly resistant. Less concerns include potential allergic reaction with oral vancomycin and the rare but reported side effect of kidney dysfunction or hearing loss. What these studies do tell us is that we need a randomized trial or comparative effectiveness trial on oral vancomycin. Next slide. So liver transplant for PSC accounts for 2.6% of all pediatric transplants, very similar to the rates that I showed you for autoimmune hepatitis. Also similar to autoimmune hepatitis, PSC can recur in the transplanted liver. A review of 5 of the largest retrospective studies of children with PSC revealed that in 208 patients with a follow-up of 5.8 years, the incidence of recurrent PSC was approximately 17%. Next slide. So there are many future trials being proposed or initiated for the treatment of PSC. These include a randomized, blinded comparative effectiveness trial of oral vancomycin versus Ursodeoxycholic, the use of an apical sodium-dependent bile acid transporter inhibitor, and nor Ursodeoxycholic acid as potential treatments for PSC. In addition, if you go online to clinicaltrials.gov, you'll see a variety of studies that are presently enrolling, including a new study on obeticholic acid for PSC, as well as a study on the use of a monoclonal antibody to a vascular adhesion molecule that would inhibit the influx of the lymphocytes into the liver. So that's it on treatment, and back now to Dr. Balistreri.
Thank you very much, Cara. So let me try to summarize some of the key points that we heard tonight in the next slide. I think we heard the spectrum of autoimmune liver disease must be considered in all children with new onset jaundice or elevated AST, ALT, and perhaps GGT levels. Most patients with PSC are asymptomatic at the time of diagnosis and are going to be found when we screen our patients with IBD. And that differentiation of these three entities, autoimmune hepatitis from autoimmune sclerosing cholangitis, or PSC, is based on a combination of the biochemistry, imaging, and liver histology. The next slide. We also heard that the pathogenesis of these disorders remains elusive. HLA type is the strongest genetic risk factor for PSC and AIH, but non-HLA genetic risk factors differ between these two entities. Thus, it's likely that these really are distinct. And we need to learn more about the interrelationship of the intestinal microbiota, bile acids, and cholangiocyte injury, especially in PSC, because this may reveal potent therapeutic targets. Next slide. The standard therapy, as you heard, for autoimmune hepatitis and perhaps for the interface component of ASC is corticosteroids combined with azathioprine. On the other hand, there are no strategies which are of demonstrated efficacy in patients with PSC. So there's a clear need for multi-center trials which focus on these disorders. Next slide. So let's now see if we can address some of the submitted questions and comments. We will post, by the way, a recorded version of this webinar on the NASPGHAN website, www.naspghan.org, in a few days. And remind you, you can obtain your CME credit through the link posted on the registration page. So let's take some of these questions, and I thank you all for submitting these. Let's start with one for Dr. Miloff, and that is a common question. Should we do screening colonoscopy in patients with IBD and PSC at a higher rate?
Right. That's an excellent question, and the answer is pretty complex. So in adults, there are clear recommendations that any patient who has ulcerative colitis and primary sclerosing cholangitis should be screened on an annual basis with colonoscopy, since the risk of colorectal cancer is significantly increased. However, no such recommendations currently exist in pediatrics. Most patients with inflammatory bowel disease regularly are screened at least 10 years after the first diagnosis of ulcerative colitis, and then with some form of screening. So in children, definitely there is a recommendation to screen them with colonoscopy at the time of the PSC diagnosis, and after that, there are no current recommendations to do so in pediatrics.
Thank you, Tamir. Alex, someone has requested that you elaborate on what the environmental risk factors for these disorders might be. Is it diet? You mentioned tobacco. What else?
I think the environmental risk factors are still unknown in both conditions for the most part, and mainly hypothesized and with some associations. I think best evidence is for drugs, especially minocycline, being associated with autoimmune hepatitis. The link to viral infection is relatively weak. Hepatitis C has been associated with LKM and type 2 autoimmune hepatitis. To what degree EBV, CMV, and other viral infections in childhood age trigger the onset of autoimmune hepatitis is still unknown. I think the strongest the focus of research will certainly be on the microbiome in the future and how diet shapes the microbiome. Everything is currently speculation. I would like to point out that a study I mentioned, which showed reduced diversity, actually excluded patients on a vegan diet, on gluten-free diet, and other dietary intervention from that study. So they clearly had PSC, but they were not studied in respect to their intestinal microbiome. So I think it remains to be seen to what extent diet may shape the microbiome and then subsequently the disease phenotype.
Thank you, Alex. I think it's worth mentioning that early exposure to antimicrobials certainly can have an effect, both possibly for IBD and I would suspect also for PSC, so judicious use of antimicrobials in early life. Cara, there's several interesting questions related to the entity of IgG4-related PSC and whether that's a separate entity and whether you need to use a drug like oral vancomycin. And Tamir, you might weigh in also, but Cara, please start.
So IgG4-related PSC is considered a separate entity from PSC alone, and it's usually associated with IgG4-mediated pancreatitis as well. There have been no case series or even case reports that I'm aware of on the use of oral vancomycin for IgG4 sclerosing cholangitis.
Okay, great. Thank you. So, Tamir, a number of questions related to liver enzymes. And what's abnormal, what's normal, and Cara, again, might weigh in both at diagnosis and during treatment. And you might add in whether tests such as GGT levels versus alkaline phosphatase, and then imaging such as MR elastography, covering many of the questions that were asked. So feel free to roam.
Okay, so definitely when we talk about the norm, there is a significant difference between what the laboratory considers as normal versus the new normals, which were actually tested in lean, mean children. And now that we know that any elevation of ALT below 30 in boys and 19 in female is considered to be abnormal. So definitely the normals are different. Specifically when we look at alkaline phosphatase versus GGT, so as we all know, since alkaline phosphatase has different isoenzymes, and especially the bone isoenzyme, then the norm in children, especially in adolescents, is very different. So then many studies would talk about upper limit of norm in multiplications, meaning if it's less than one upper limit of norm or more than 1.5 the upper limit of normal. And that is one of the reasons why we tend to use GGT much more commonly in children, since it usually normalizes to the similar levels of adults within the first year of life, and then there is no significant age variability such as the one you see in alkaline phosphatase. Cara, is there anything you wanted to add about the enzyme?
Yeah, I'll just add to that. This may have come up when I was discussing how I start, we start the counting of 2 years of normal liver enzymes before we consider stopping the azathioprine. So when I'm specifically talking about AST and ALT, they're the most sensitive for autoimmune hepatitis. And what our routine is that when your AST and ALT are approaching normal, 1.5 to 2 times normal, we'll start our weaning of our steroids. But we really consider normal as far as when do we start counting for that 2 years of normal liver tests. We consider normal whatever the range of our laboratory is for normal. So our goal is always that you normalize the ALT and AST with isolated autoimmune hepatitis.
Great, thank you. Would any of the three of you like to comment on the question regarding imaging, MR, elastography, or RFE, or anything that might give us a marker or a biomarker to follow these patients?
Right. So this is definitely an area that needs a further investigation because we all want the holy grail of non-invasive markers of disease progression. And what is specifically unique about primary sclerosing cholangitis is most non-invasive markers look at the classic portal fibrosis that you would see in any degree of chronic liver disease. However, in primary sclerosing cholangitis, you may also have periductal. There may be a different kind of fibrosis, which to date, we don't really know how to categorize best on non-invasive testing. So the common ones are used, are the FibroScan and the shear-wave elastography, which is via ultrasound, and definitely an MR is available on older patients. However, as we all know, in pediatrics, when you need sedation, it may be somewhat a little more challenging.
Great, thank you. So, Alex, getting back to the microbiome, at least indirectly, one of our participants questions the role for probiotic therapy in PSC. And I will extend it to a patient with IBD who you're worried might be at risk. Alex.
Yeah, I think that remains to be seen. There's no evidence that it would help. I think the decreased intestinal microbial diversity, whether that is the chicken or the egg, and whether targeting diversity helps, that would have to be studied in larger series. I don't think that we know whether it helps. We don't know.
Great. So there's a question about the theory behind why Urso in the adult studies of Keith Lindor et al. Caused adverse outcomes. I'll address that briefly. The theory, which was shown by some of their subsequent studies, is that there is a conversion to lithocolic acid, which is not a good bile acid to have circulating. So that's the theory. Whether that's true in the pediatric population and how it relates to the microbiome, here we go again, is not known.
Mm-hmm. Right, and I think that's hard to compare the adult study to our children because we use at least a third to half the amount less of ursodiol than they used in that study.
Right, exactly.
They used high dose, yeah.
So, Tamir, here's a question for you. In an obese patient, which I think many of us will see, with an elevated BMI and elevated ALT and AST, when do you pull the trigger and say, could this be autoimmune hepatitis, or what lab test would trigger you to consider autoimmune hepatitis? Good question.
That's an excellent question because this is definitely part of the struggle that we deal with on a regular basis. So we know that there could be some elevated autoimmune antibodies even in patients with non-alcoholic fatty liver disease. So if the titers are extremely elevated, I would say above 1 in 80, and there is also elevated gamma globulins, then definitely the pendulum would lean more towards autoimmune hepatitis. However, if there is obesity, other clinical markers associated with non-alcoholic fatty liver disease, such as acanthosis, central obesity, and the autoimmune markers are just mildly elevated, then I think it would be fair to assume that this is non-alcoholic fatty liver disease. However, definitely a diagnosis of autoimmune hepatitis is not a diagnosis you would want to miss, since we do have good therapies and the disease would otherwise progress. So whenever in doubt, that is the time to use the needle and histology, which could be extremely helpful in differentiating between these two.
Well, this is an important issue. Let's have Alex and Cara weigh in very, very briefly on any different strategy.
Yeah, our obese kids, if they have a positive ANA, and we consider 1 to 80 positive ANA, not 1 to 40, because up to 10, 15% of the population is ANA positive. So true positive ANA, or of course any positivity in anti-smooth muscle or LKM, we would proceed with liver biopsy even in our obese kids, just to ensure that they don't actually have both NAFLD and autoimmune hepatitis.
Great. Alex, any comments?
Nothing to add. I think I can only emphasize the importance of a liver biopsy in that context. There's no way to otherwise differentiate autoimmune hepatitis from NASH in a patient with obesity and elevated autoantibodies.
Thank you. I know we were scheduled to end at 9:15, but given the large number of questions, if you'll indulge us, we'll go on for a few more minutes. So let me address this to Cara, a very interesting question which we've had to deal with, and that is, what about the young patient with autoimmune hepatitis, especially that patient that perplexes us all, the giant cell hepatitis hemolytic anemia? Is this in the right category, and how would you treat?
Oh boy, that one I may have to defer to someone else, because we actually have not had any cases of that in the past decade. So Bill or Amir?
I can give you our experience, but George Bazan and I, we had a couple of patients that we treated. We ended up treating with a whole gamut of medications and immunoglobulin, and ended up using Prograf with good results, treating them just like a post-transplant patient. Alex, Tamir?
But it's also, of course, reported cases that rituximab as a first line, right? And those with associated autoimmune hemolytic anemia. And then the second line would be then calcineurin inhibitor.
Right. So I've also had a patient successfully treated with rituximab in this case.
So, Cara, several questions about the dose and of two of the drugs that you mentioned. To reiterate, budesonide and oral vancomycin, should someone choose to use these. And Urso while you're at it.
So budesonide, all of the studies are based on a starting dose of 9 milligrams daily. And then once, again, we treat similar to if we had them on prednisone. Once your liver tests are near normal, then you can start weaning, and they come in 3 milligram tabs. So the easiest is to wean by 3 milligrams slowly over a few months. So 9 milligrams is the starting dose. Ursodeoxycholic acid, we are, as the two other institutions on this webinar, are part of a FDA study looking at ursodiol in children and what happens to the enzymes when you take them off ursodiol and then reinstitute the drug. And in that study, we max out at 300 milligrams twice a day. So that even before this study was our group's standard of care to pretty much max out ursodiol at 300 milligrams twice a day. And then oral vancomycin, the studies, all from Ken Cox, the pediatric studies, the maximum dosing is 500 milligrams per dose 3 times a day. That's the maximum dosing. And for the younger kids, it was 30 milligrams per kilo per day divided 3 times a day. So that's what the published literature used on that. It's pretty high dose.
Thank you, Cara. So I'm going to ask Alex, Tamir, Cara if they have any final closing comments before we end the webinar.
I would like to add to the budesonide, because that has gotten some traction and treatment. That the evidence, of course, is not as strong as in adults. In our case report in our center, we have seen some positive results, but especially the reading is still unclear. And most patients, basically, at least in adult centers, remain on 3 milligram budesonide once a day. And another comment, which I believe is important, learning from adult experience, is that in times when treatment aimed at AST, ALT below 100, the outcome of autoimmune hepatitis was much worse than when the adult colleagues started to get patients into true biochemical remission. So the questions about what is normal and what to aim for is probably highly relevant in treatment.
Exactly.
I would like to share an anecdote in regards to infliximab, because there are some studies that actually show that infliximab to treat inflammatory bowel disease may be helpful in treating autoimmune hepatitis. However, infliximab may be a double-edged sword and has also been associated with drug-induced autoimmune hepatitis. So it is very important to monitor patients who are receiving infliximab with inflammatory bowel disease.
Terrific.
Yeah, there has been a case report on infliximab use in autoimmune hepatitis and inducing remission. However, I would caution, we've got lots of kids on infliximab who develop autoimmune hepatitis, and they need to go on the standard steroids followed by azathioprine. So I think in the majority of cases, infliximab alone is not going to be sufficient to keep autoimmune hepatitis in remission.
Yeah, I would agree.
Correct, and I would even emphasize the importance of screening patients with IBD and infliximab for the development of autoimmune hepatitis.
Well, terrific. I want to thank our faculty for sharing their time and wisdom with us. It's been a terrific evening. And once again, thank NASPGHAN and the NASPGHAN Foundation for sponsoring this symposium, Chris and John Browner for providing support, and the organizations that have endorsed this program. But, of course, we must extend our thanks to all the participants in tonight's webinar. So thank you and good night.